You're listening to the McGregor Dementia Support Ministry podcast. Today's episode is our live Q&A panel discussion from the February 21st, 2026 Alzheimer's and Dementia Seminar at McGregor Baptist Church. And in this conversation, Dr. Ed Shaw, Dr. Benjamin Mast, and Cynthia Perth Hughes respond to audience questions about dementia, Alzheimer's disease, caregiving, faith, and a host of a whole bunch of other topics. This session offers practical insight drawn from real life concerns. On the panel is, we've already introduced Cynthia and Dr. Shaw and Dr. Mast. Glad to have you guys back. This is a lot of fun, isn't it?
Yes.
All right. Dr. Shaw, I'm going to start with you right there in the middle. And you possibly dealt with some of this in your breakout session, but not everybody was in the breakout session. But several questions that came in early were dealing with how do I handle aggressive behavior as a caregiver with somebody that I care dearly about. What are some things that we can learn, that we can do that could in handling and dealing with that aggressive type behavior?
Yeah, so this is a common question. I think aggressive behaviors tend to happen a little bit later in the journey with Alzheimer's or another form of dementia. Sometimes people who are living with frontotemporal dementia, they may have aggressive behavior as one of the front row and center issues. Or people, we were talking in the last breakout session about people who have a delusion that maybe somebody's trying to hurt them, and they may respond aggressively to the person who they feel is trying to hurt them. So the answer to the question is somewhat dependent on the situation. So I'm going to give a short response, and then we'll value hearing what Dr. Mast and Cynthia have to say. I think the most important thing is to just drop the temperature of the situation. That if somebody is acting aggressively, if they're yelling, they're screaming, they're hitting, they're kicking, you want to just lower the temperatures. It was in one of the caregiver testimonials, somebody said something like that you want to try and calm the situation. I will often have the person try and sit down, because often when they're aggressive, they're pacing, and there's a lot of movement there, and you just want to ground them in the chair. So sit them down, talk in a quieter voice, because you're literally modeling like how it is that you can calm that person's behavior. Make eye contact. Well, Cynthia, you seem upset, but it's okay. And then just kind of try and bring calm to the situation. Right. So I'll stop there.
Yeah, that's good. Cynthia, do you have any thoughts?
I like to give the suggestion that you change the subject, change the topic. If they're upset about, I don't want to eat this food, this is not what I want for lunch, I told you I didn't want this, and I can say, that sounds great. Would you like to go outside and look at the birds? I saw some beautiful birds outside. And we just distract and just turn in a different direction. And again, also body language is really important, as well as being on the same level. If they're sitting down and you come in and they're upset and you're standing above them, you really need to get at the same eye level. I spend a lot of time on my knees with my clients because I want to be at the level where they are. You also don't want to come up from behind them and surprise them or touch them without asking for their permission for you to touch them. Just some things that are just a little bit of common sense, but that we don't use maybe in our daily lives.
Yeah. Dr. Mast, let me kind of tag with that, and a couple of questions came in. Not asking it this directly, but asking, why is the person with Alzheimer's dementia acting in a way that just doesn't seem so Christian anymore? I don't see the fruit of the Spirit in their life anymore, and the anger and some of the other things. So how would you respond to that person asking that question?
Yeah, I mean, it's a great question. It's very upsetting and disturbing at times. A person has really changed the way they interact with you. Maybe they say things they didn't used to say, they do things they didn't used to do, and it's not okay in terms of what they believed and how they are. But I think if we go back to, a simple answer is if we go back to that image that Dr. Shaw showed earlier of how much the brain has been affected. He showed those two brains next to each other, and just the significant damage and shrinkage to that tissue is showing, this is a person who's living their everyday life like you or I. They want to understand, they want to connect, they want to make sense of things, but they're doing it through a very different lens. And it's important for us to remember, the brain has been very heavily damaged in some of these cases. And so maybe the things that maybe they thought but didn't say, or felt like doing but didn't do, now becomes much harder to suppress, right? So if I were up here and I took my water and I accidentally spilled it all over myself, in my head I might think something that I wouldn't say in front of the crowd. But when your frontal lobes are degenerating, it might slip out more often, so to speak. It doesn't mean I'm not a Christian, I don't think. It means, I get frustrated, I get angry, I get embarrassed, and sometimes those things come out in the behavior.
So patience and endurance
Yeah.
in dealing with that. This is a question that I think I'm going to be able to answer. The intro speaker mentioned that the session is being audio recorded. Will that recording be made available online so those who could not attend can access it? It's a very good question. We are recording, as I mentioned, all of these sessions. We have been doing that for several years for this particular seminar. If you listen to podcasts, audio podcasts, you can go to do a search either on Apple Podcast or Google Podcast and go to McGregor Dementia Ministry. You can also go to our website and you can get to them directly there as well. And thank you for putting that screen up there, Bobby. But most all the past seminar sessions are available over the last several years, and these will be available as well. Now, they won't be available tomorrow, so don't start looking for these tomorrow. It'll take us a little time to get those uploaded, but within the next few weeks, we will try to have those up there. But what's nice is you can go back and listen to stuff from last year and be able to get benefit from those as well. So, man, asked my own question and answered it. I love it. All right. I love this. I'll start with you, Cynthia. Why is it that many with Alzheimer's in the family do not want to talk about it, not share with other family members? And how can one go about changing that kind of dynamic?
I believe that the reason people don't want to speak about it is because they don't understand it. So as I mentioned, my father had Alzheimer's. My grandmother died. My dad's mother died with what we called old timers, and my great-grandmother died with senility. And when my great-grandmother died, she died close to 100, but she lived in a trailer behind my uncle in Arkansas. And as small children in the 60s, we would run and make fun of her because we thought she was a witch living out in the trailer. And no one corrected us, and no one explained to us or educated us on what she may have because they didn't know and they didn't understand. So when we came back I grew up in Dallas, when we came back, we didn't talk about our great-grandmother. We didn't talk about seeing her or anything about her because we were afraid of her and we didn't understand her, and she talked in nonsensical language and she smelled really bad. And so my goal in my life is to try to change that stigma, and that's why I talk about what I talk about, and I'm very honest and very frank about it because I don't think there's anything to be embarrassed about having Alzheimer's. I don't think there's anything embarrassed to having a mental illness or having an addiction. I don't think it's an embarrassing thing, but we don't talk about things that we don't understand or that we're afraid of. And I also know that a lot of adult children that I work with don't want to talk about it with their parents, and I believe that part of that is because they're afraid of what their mortality may look like, and they're afraid that it runs in their family. So if we can all embrace that this is not anybody's fault that they have it, it's not because, as I mentioned earlier, they drank too much, sometimes that can cause it, but because they lived under power lines or because they swam too much or whatever, it's not because of that. It is a disease, and I just believe we all should be more open about it.
And obviously, too, by not talking about it, you're not dealing with it, so you can't get help that you potentially could get for any of these things. But any other thoughts of helping maybe break the stigma? I know I'm grateful for our church that we're trying to talk about it. We're trying to say, hey, let's get the conversation out there. We can provide resources. But any other? Oh, okay. Any other thoughts?
Yeah, I think Cynthia really nailed it there. I think there is stigma, and I think people are terrified.
Yeah.
And I think one part of that is, they saw a parent or an uncle or a grandparent, and they see it, and they saw maybe the disease at its worst, and they're afraid that that's what their path looks like as well. And I think as we change some of the stigma and improve our understanding and care, maybe some of those scenarios won't be quite as bad as we envision them becoming.
Yeah, absolutely.
Can I add one more thing?
Oh, sure.
When I found that I had the APOE4 gene, and I didn't talk about it for a while, and the reason I didn't talk about it was because I had the false perception that the insurance company would never cover my care again, and so I didn't want them to know for whatever reason. When I began to talk about it, friends of mine said, "Why would you tell people that? Why are you talking about it? Aren't you afraid for them to know?" And I had to get through that. My friends don't do that anymore, and they embrace it, and they join in with me on the Alzheimer's walk, and they say, "I'm going to come and listen to you at McGregor," and I say, "Come on." So it's different, but 20 years ago, people were not understanding when I would talk about it.
Yeah, absolutely. Do you have anything to add? Ed?
I guess I would agree with everything that Cynthia and Dr. Mast said. The other thing I often hear is, well, I don't want to be a burden, or I don't want to burden them. But my experience in the majority of families is that, the adult children would never think of caring for their mom or dad as a burden. It would be a privilege and a joy. Yep. And I think also by sort of hiding the white elephant in the room, you deny the person of knowledge and information because it's not in the open. And, look how we've benefited today from all the knowledge and information that has been shared. So, yeah, it's a really common issue.
Absolutely. Dr. Mast, you're a very active person, so I'm going to ask you this question, and y'all can follow up. They say that being active can mitigate the risk of Alzheimer's. Is that true?
It depends on what you mean by mitigate. So I think, as Cynthia said, the data is pretty strong that it can lower risk. What's good for the heart is what's good for the brain. And so physical activity is one of those things that can lower your risk. Does it fully erase your risk? Of course not. Right. We all know, just like we know people who didn't get it and lived on cigarettes and bacon, we know people who are incredibly active who became very confused and forgetful. So it's one of those, what I would call data-supported prevention activities. But when we talk about prevention, we're talking about reducing risk and delaying onset of symptoms, which doesn't sound as exciting as prevention. But if you could delay the onset of Alzheimer's by 5 years across the country, you'd cut the rates in half. Yeah. And so we are talking about delay.
Yeah. I loved Cynthia's little, in fact, I tore it out, the healthy habits for your brain little slide that you had up there. And if we actually took serious those things, talking about potentially mitigating some of the risk, and one of those, is get moving, and exercise is part of that. Anything else anybody want to add on that?
I believe that following those can mitigate or delay a lot of diseases.
A lot of diseases.
It's not just about Alzheimer's, dementia. It's a lot of things.
There's not a lot of bad side effects of start moving and exercising. Those are usually all upside. Cynthia, you mentioned just a moment ago that of your APOE4 gene. And so this person asked, does insurance pay for genetic testing for that particular gene?
I can't tell you that, but I can tell you that I went through a lot of testing in the summer with a neurologist, and it was all covered because I had a family history. So I encourage people, I think it's up to your individual insurance policy what it will cover or not cover, but just ask.
But it was covered. And they were asking also, can you get tested before you have a diagnosis of MCI? And obviously you don't have that diagnosis,
Yes.
and were able to get tested, and it was covered by Medicare, you said. Anybody else know any experience on that? There was another question that kind of related to that. How may I be tested for the gene? What is that process like? Is it just a simple blood test?
Mine, there are a couple of ways. You can do a blood test. I did a spit test. And you can also have a lumbar puncture, which I did not do.
Oh.
I mean, are there other, am I missing one?
No, I think like Ancestry.com does test your ApoE4 gene status. What they don't do is test your ApoE2 gene status. So you have ApoE2 genes, ApoE3 genes, ApoE4 genes. If you have one or two copies of the ApoE4 gene, you have an increased risk. It doesn't mean you're going to get Alzheimer's disease. It means your risk is elevated. The ApoE2 gene is a protective gene. So, and that to me is just as important to know.
Yeah.
So it may be that if you have one or two copies of the ApoE2 gene, it may balance out your ApoE4, or if you didn't have ApoE4 but you have the ApoE2, maybe you'll be at lower risk, and I would like to know if I had lower risk. Yeah. So I think genetic testing it's a mixed bag.
Yeah.
And I feel like it's probably not ready for prime time for all of us to just routinely get genetically tested or go out and get the amyloid blood test. There may be pathways in the future for that.
For that, yeah, absolutely. And I'll let whoever wants to answer this, but they were asking, can we have more information about Parkinson's disease? Even the dementia seems like it is very close to Parkinson's. So maybe distinguish between the two, and maybe give us a little bit of how some of this
you start with that.
Connects.
We talked about this a little bit in our breakout. So Parkinson's disease is a neurologic condition. An important distinction to make is that not everybody with Parkinson's develops dementia. They're not the same in that way. That people with Parkinson's disease will typically show the physical symptoms, some cognitive slowing, and some people then will go on to later on show some cognitive decline that would meet criteria for dementia. But Parkinson's disease in itself is not a dementia, even though it's affecting the brain. To complicate it a little bit, Lewy body dementia is similar to Parkinson's disease, same Lewy bodies in the brain, but they start in a different location. So they're kind of siblings, but in Lewy body disease you see the cognitive changes and the physical come later. In Parkinson's disease, people have the physical movement changes and don't always show dementia.
Yeah.
Would you add or amend that?
I guess I would say that we are now better able to understand what the bad proteins are that are causing brain inflammation or causing the brain to shrink, to kill neurons. And I think in the future, both what we call these diseases will become more related to the underlying bad protein, like Lewy body that you mentioned. In Lewy body dementia, we know that's a protein called alpha-synuclein, and we will eventually develop treatments that get rid of the alpha-synuclein in the brain. And so as the science advances and we understand the process better, the treatments and even how we name these diseases will change in a good way.
In a good way, yeah. Let me ask you this, and this is, some people had asked earlier on about what are some of the symptoms in late stage dementia, but also I have the question of, okay, somebody, they say they died of Alzheimer's or dementia. What does that mean? What did they actually, how did they die? Going to the doctors here on this one, probably.
So the cause of death for 40% of people with dementia is aspiration pneumonia. It's where the person in the late stage, doesn't matter what dementia you started with, by the late stage they sort of all look pretty similar. And in the late stage, the person becomes incontinent and they have difficulty swallowing, and they start to swallow food or liquid rather than into their stomach through their esophagus, their swallowing tube. It goes into the trachea and into their lungs. And that sets them up for aspiration pneumonia. And aspiration pneumonia is because of swallowing liquid or food into your lungs. So that's the cause of death.
Okay.
It's not the dementia itself, but it's an indirect thing.
Yeah.
But eventually, if a person who has dementia, the disease will affect the brainstem, which is kind of the part of the brain that controls like breathing and heart rate and kind of the main bodily functions, and it will turn off the brainstem.
Yeah. Cynthia, I'll ask you this: has there been any research that you're aware of? And I'll ask all of y'all, but I'll start with you, for the reason why we see such an uptick in the number of cases. And I know this is somewhat, your opinion, but I'll give everybody a chance to kind of share why we see this dramatic increase over the last, 10, 20 years.
So my opinion is that this is a disease of old age, and we are living a long, long time. And so it's just natural that a disease of old age is going to show up. I believe also that the stigma is being loosened up a little bit and that people are talking about it more. So we see it more because it's being talked about and because we're old.
Yeah. Any other thoughts on that?
Yeah, I think I was going to say the same thing. Age is the biggest risk factor, and as people live longer, the number of people who have dementia goes up. But paradoxically, there's some new evidence suggesting the percent of people who develop dementia is actually going down because of lifestyle improvements. So it's both. Because people are living long, we see more cases, but the percent of people who develop new cases every year is actually lower than it used to be.
Oh, interesting. Yeah. The same person asked, why do amyloids develop? What is the mechanism there for that? Oh, we stumped the panel. Look at that. Whoever asked that question?
This is not my level of expertise. There is an understanding that these amyloid precursor proteins are part of a normally functioning neuron or brain cell. And early on in Alzheimer's disease, there's an enzyme that acts upon it, and it snips that protein into fragments. They cluster together. The brain can't clear them and leads to cell death. Now, if the next question is, why does that enzyme do that, then I'm stumped. That's the end of my knowledge.
You're out, huh? Cynthia, is dementia, Alzheimer's, a diagnosis to get Medicare at an earlier age than 65?
Not that I know of, unless it's under disability. I don't know.
Yeah.
I don't have an answer. Sorry.
I do believe that I think our attorneys have. Oh, they may be on Main Street. I do believe for disability that if you have a diagnosis of Alzheimer's, you will automatically receive disability versus other medical conditions.
Okay.
So.
And this was, I guess, a follow-up, Ed, from your earlier presentation in here when you were showing the chance of death with some of these new drugs, the 1% chance. Is that dependent on the amount of amyloid that was removed and the type of treatment, or I'm not sure exactly what they're asking there, but I think they're just questioning what's the cause of that 1% chance of death there?
Yeah, so the side effects, the brain swelling, the brain hemorrhage, the stroke, and if those were severe enough that any of those things could result in death, is a consequence of, the drug is called a monoclonal antibody. So it's going in, it targets an amyloid molecule, and then through an immunologic mechanism, it removes it from the brain. And I think just like we saw with COVID, some people would get, this COVID lung disease that could be life-threatening or fatal, and that was an inflammatory response for reasons we don't entirely understand. Some people who get the treatment develop this kind of inflammatory response in the brain. And when the brain swells It can rupture a blood vessel, and there can be a hemorrhage, or it can cause a blockage and a stroke. Any of these things are possible. And though people who have the ApoE4 gene are more likely to have that as a complication, it's just like with COVID. Some people didn't survive it, but most people did. We don't really understand the factors of why that was.
And kind of a follow-up, another person asked, when you showed, I think it was you that showed the scans after somebody had been on the treatment, how it looked like it had cleared, but yet they didn't see the benefits of that with the cognition. What is the reason? Is it because the damage has been already done?
Yeah, I think probably it may be, even though the structure of the brain returns to normal, the amyloid is gone, there's still a functional issue. But I don't know, do you have another thought about that?
Yeah, I think it's very surprising, right? So we stand up here and say these amyloid plaques are the primary, or at least we think the primary cause of Alzheimer's. They lead to these cognitive changes. Then you develop a drug that removes them and the cognition continues to decline. So either we had the wrong target or the damage is already done. These are, at this point, scientific hypotheses that maybe even though it's early symptoms, maybe it's still too late. There are trials undergoing now where people are taking these anti-amyloid treatments in the asymptomatic or pre-symptomatic phase to see if that works better. I think we'll know more. But keep in mind, there are two pathological changes. There's plaques and tangles, and so we've affected the amyloid, and there's still the tau.
Yeah. Dr. Mast, I'll ask you this, because we were actually having a conversation about this earlier this morning. This person said, I've heard there is a lot of research on the benefits of creatine, monohydrate, and brain health when used prior to full onset of Alzheimer's and dementia, or MCI. Any thoughts on that?
Well, I have seen the data on creatine. I'm also a creatine user. So we talk about supplements. That's the one that I have chosen to take. And from what I saw with the data, I thought it looked pretty promising. I think the challenge in science is always replication, and that means can somebody else show similar results without a significant side effect? N of one, I take it. I feel like it does good things for me overall physically, but I'm not taking it for my memory.
Yeah. And it's been around a long time.
It's been around a long time.
Yeah, it's not something that's just popped up recently.
Yeah, I would say if you hear an expert on the stage talking about what they do, we should revisit the wisdom of going to your doctor and say, does this make sense for me to do? Right. Maybe it wouldn't be good for other parts of your bodily systems, whereas for me in mid-50s, maybe it's okay. Yeah. And your situation might be different. So don't start it because we talked about it.
Always consult your physician, right?
Always.
Yes,
or a nurse
absolutely.
practitioner. Yep.
Dr. Shaw, I'll start with you, and y'all can all answer. But here's the question. How do you best help your loved one who denies having any issues, although they are very evident, and becomes defensive and very accusatory when we try to talk to them about what we're seeing and concerned about them in their life? They insist, underlined, nothing is wrong.
Yes. So this is a really difficult challenge, and I think it's common and frustrating. I think there are two things that may be going on when somebody is, quote, in denial. They may really understand that something bad is going on with their brain, but they are truly in denial. In other words, it's painful for them to acknowledge that reality. And so their defense mechanism, as we call them in psychology, their defense mechanism is to just say, no, there's nothing wrong. And I've had brain cancer patients who have flat out said, I do not have a brain tumor when their scan shows it. I think the other issue is insight. So insight is our ability to understand a situation that we're in. And we know that insight is a brain function, and that function is affected adversely in people who have Alzheimer's or other forms of dementia. So it may be that they don't really understand. They don't have the insight to understand there's something wrong. That's really either way, it's a challenge to get them into the doctor.
Yeah.
I say, if you're concerned, if the person has more cognitive challenge than you think is normal for their age and you want to get them evaluated, you can use threats, bribes, guilt, shame, or if you need to, brute force, and to get them to the doctor. Yeah. But, sometimes people just won't go.
Yeah. If somebody is, let's say, 87, 88, late 80s, and they're starting to have some of these symptoms and they're in denial, is that a point where you would say, yeah, you got to get them into the doctor for that? Or is there a point where we're just going to let this play out?
That's not how I think about it. I think it really depends, because one person might be 88 and very frail and sick. Another person might be 88 and quite healthy and have many good years left to live, which isn't to say if you're 88 and sick, you don't. But I think the question you're implying is there a point in which the battle is not worth it? And so maybe this is just deflecting, but I wouldn't make it based upon the age.
Right.
And maybe you could consult an expert like Cynthia and just say, what would you do? I mean, you're good at navigating these waters. Should we try to force the issue, or does this make sense to let it go and do the best that we can? I think the danger is when we make age the criteria, that to me starts to feel a little bit risky.
Yeah, that's a good point. Anything else?
Well, I also think that sometimes the mistake is trying to force our perceptions on what they should be doing, and that they should be going to the doctor, or they should listen to me because I'm the expert, or I'm the child, and I know, and I want you to do this, and I want you to do it for me because I want to understand what's wrong with you. When maybe it's just about an easier way of going about it. When I mentioned that I'd had a full battery of tests this summer with the neurologist, and she said to me, "Why are you here?" And I said, "Because I want to see this coming. I want to know if I have it." And she said, "You'll never see it coming. You need to hope you're around somebody who sees it for you." So it's that's a true statement, that they just don't have the capacity to maybe understand that there is something. So there's the denial, but there's also the fact that they just may not see it.
Yeah, and going back to dealing with it earlier, when they might be able to not so vehemently deny it, might be of value as well, instead of waiting and waiting. Maybe it's not. Let's let it get, and then it gets worse. This is the last question, and this is, I saved it for last, just like you usually have dessert at the end, but here's the question. What is sugar's role in brain health? Yeah, you don't want to hear this one. Just cover your ears. But
I have to start, and I'm gonna throw somebody under the bus out here, but I'm not gonna look at them. She asked me if I was speaking in March at a group where she belongs, and I said yes. And she said, "Well, I'm gonna come and hear you, but I was thinking I wasn't until I actually saw you and thought you were fun." But because I knew you were going to stand and tell all of us to get rid of sugar, and I didn't want to hear it. And I said, "Well, I'm not going to tell you that, but." I am a believer that sugar is the evil empire, but that doesn't mean that I might have a piece of cake for breakfast, okay? So I think that sugar it's just my opinion. Again, I'm not a doctor, but I believe that it is something that affects a lot of our body issues, arthritis, inflammation, a lot of things. So I try to keep it away as much as I can.
Keep it in check,
but that's just, I'm not a doctor.
Yeah. Anybody else want to jump in on the?
You're an actual doctor.
You're an actual doctor.
So there are some who believe that they call Alzheimer's disease type 3 diabetes of the brain. And in fact, one of my colleagues at Wake Forest University, her main area of research is using intranasal insulin. So you basically, instead of insulin shots, you squeeze insulin like you were taking a nasal spray, and you absorb it up into your brain. And she has some data that would suggest that that might actually help cognitive function. So it seems like sugar mismanagement plays some sort of a role. I think also some of the dietary approaches, there's keto diets that Cynthia showed, which are very low carb diets. They're high in protein, high in fat. There are potential issues with that. Even a Mediterranean diet doesn't eliminate sugar, but it definitely moves you towards sort of food in its natural form, whole grains and fruits and vegetables, things that are healthy. And I believe sugar, in the sort of pure sugars or in processed foods, may be responsible for some of the wave of Alzheimer's disease that we see. But is it only a sugar issue? Probably not.
Probably not, yeah.
So,
you made it sound nice, mismanagement of sugar.
I love that phrase. I'm going to use that phrase now.
Yeah.
Mismanagement of sugar. I love it.
That's what I did last night, eating that carrot cake. Mismanagement of my sugar. Yes. All right. Anything else to wrap us up?
Well, so I'll play the role of psychologist and say, well, it depends, right? You should consider it in the context of your life and your health. If you are, there are some situations where sugar is energy, and it needs to be there because the person is exhausted. And so I don't think it's the kind of thing and there's other people where sugar is a real issue in terms of management and the effect on the blood and the brain. But you want to consider it in your overall lifestyle. So there probably aren't a lot of situations where you should either prescribe yourself more sugar or completely drop it out without consulting a health professional. And so there are situations where sugar can be quite good. And I don't work for the sugar industry, just to say, it does have some beneficial effects in some situations for some people.
Yeah.
So.
All right. Well, thank you all so much for going through the hot seat here with all the questions. You all did great. Give them a big hand. We're grateful you joined us for this panel discussion. If these answers were helpful, subscribe for future episodes and share this resource with others navigating similar questions.